Look, a little girl and a little boy. If nothing changes, he will grow up to be the medical norm. And she, as a woman, will remain the exception. An imbalance that benefits no one. Yes, men and women differ in every cell of their bodies. The world of science, though, has been designed for one of them, creating a gender health gap that is not getting any smaller, as we heard last year.
The last decade, inequalities have increased and not decreased.
We also know the numbers, that women are diagnosed 4 years later for 770 diseases. They spend 25% longer in poor health, often because they simply can't get access to healthcare.
Access to services for many women is limited, and services are really not available.
And even if they make it, women are often treated like men, even though many diseases affect them differently. We know that women have higher rates of anxiety and depression, that they feel more pain but receive fewer painkillers, and that they are twice as likely to suffer side effects from medications. Why? Because women were not well represented. For decades, they were underrepresented in clinical studies. While that is changing, decision-making is still dominated by men. Women hold 70% of healthcare jobs, but only 25% of leadership roles. And finally, it's no news that changing all this and closing the health gap would benefit everyone. The global economy alone could gain more than 1 trillion euros by 2040. So, why are we still here in 2025?
Why indeed? Why are we still here talking about a problem that we know so well and that has been public knowledge for so long? What better question could there be to launch this World Health Summit event hosted by Daiichi Sankyo? Hello and welcome, dear guests. I'm Melinda Crane, and it is a great pleasure to accompany you today as moderator. I am a political journalist and also an economist, and I frequently work in this area of healthcare and pharma innovation. So it is a special honor to be able to moderate this panel entitled Breaking Barriers to Advance Women's Care in NCDs, Women-Centric Solutions for Driving Health Equity. And in our film just now, you saw clips from the outstanding panel that our host convened at last year's World Health Summit 2024. This year, we want to continue that conversation because there is still a lot of work to be done to close a gender gap that begins with underdiagnosis of killers such as cardiovascular disease and cancer, and spans inadequate treatment, as well as lack of specific women-centric data and focused R&D. So once again, we're asking what all of us here can do, both on our own and together, to ramp up efforts to drive real, meaningful progress for women. Over the next 90 minutes, followed by greetings from our host and a keynote by a renowned global health advocate and thought leader, we will explore the impact of the glaring gender gap and take a deep dive on targeted solutions to prioritize women's health in prevention, treatment, and control of non-communicable diseases in general and cancer in particular. We have an outstanding panel with us. I will take this opportunity now to greet all of them, and I will introduce you in more detail when we start our panel discussion. Now, it is my great honor to hand over to our host, the Representative Director, President, and CEO of Daiichi Sankyo, Hiroyuki Okuzawa-san. It is a pleasure. Please, you have the floor.
So, ladies and gentlemen, and distinguished panelists, it is a great honor for me to open this vital session on breaking barriers to advance women's care in non-communicable diseases. I look forward to an open exchange of ideas on how we can work together to improve women-centered solutions and promote health equity. We have just seen a powerful video that reminds us the gender health gap is real. It begins early and persists across a woman's lifetime. That is not a women's issue. It is a health system issue, a research issue, a societal issue, and an economic issue that affects all of us. We at Daiichi Sankyo believe that addressing women's health is not just as a matter of equity. It is essential for achieving our purpose of contributing to the enrichment of quality of lives around the world by creating innovative pharmaceuticals that address diverse medical needs. Non-communicable diseases are the leading causes of death for women globally. In cardiovascular, women's symptoms are often misdiagnosed or undertreated. Women are historically underrepresented in medical frameworks for research, diagnosis, and care. In oncology, many gaps remain in women-centered care, from prevention and screening to access to treatment and long-term survivorship. Behind these challenges lie deeper structural issues. Women have long been underrepresented in clinical research. Many health systems lack funding models that address women's specific needs, and women are still not fully included in healthcare decision-making process. This is the reality we must change. And we at Daiichi Sankyo are committed to contribute to this goal alongside other global health partners. As a company, we believe that addressing women's health is not just a matter of equity, but a critical step toward better patient outcomes for all. Our scientific focus is clear. We work to address some of the world's most complex diseases with a focus on cancer and cardiovascular health. With passion and dedication for patients and science and technology, we are committed to advancing high-quality, high-impact innovation. This includes a broad clinical development program in which we ensure a fair gender balance that represents women according to their epidemiology in each disease. With our strong presence in the field of targeted cancer treatments based upon antibody-drug conjugate, ADCs, we support patients around the world, many of whom are women living with metastatic breast cancer. Our goal is to become a global top 10 company in oncology by 2030 by bringing at least 5 marketed ADCs in more than 30 indications, including many women-specific cancer, such as breast and multiple gynecological cancers. With our science and technology, we want to support nearly 400,000 cancer patients with our treatments by 2030, thereby improving standards of care and reducing unmet medical needs in cancer. But innovation alone is not enough. We believe that the best science starts by listening. We turn insights from healthcare professionals, patients, caregivers, and advocacy groups into action. We also strive to reflect these values in our own organization to promote the sustainable development of societies. We create an inclusive workplace and supporting women in science and leadership roles. As we look ahead, I'm convinced the key to advancing women's health lies in collaboration. No single sector can solve these challenges alone. Traditionally, Japan has a concept known as Sampo Yoshi, or the three-way good, as the ethics of commerce, which means good for the seller, good for the buyer, and good for society. This powerful concept guides us at Daiichi Sankyo, even beyond business. We want to create shared values and work alongside multiple stakeholders across countries and regions and across sectors. Most importantly, with patient voices at the center to improve patient lives around the world. This session today reflects that spirit. We are honored to be joined by experts from diverse disciplines and geographies. Together we have the knowledge, the experience, and the motivation to drive progress. Let me conclude. We began this session with a powerful video that reminded us all of the inequity that still affects women's healthcare. Let us use today's session to move forward with determination. The barriers are real, but they are not immovable. At Daiichi Sankyo, we are ready to work with all of you to advance research, improve care, and close the gender health gap in non-communicable diseases. Thank you very much.
Thank you. Please stay with me if you would, because I just have one question for you, Okuzawa-san. And first, let me say thank you very much for those very powerful messages, which we will be picking up on in our discussions throughout the session, and also for the company's deep commitment to breaking down the barriers. So as I think you know, we are very eager to showcase concrete examples throughout our session. And therefore, maybe you could share just one or two examples of how you are working in practice to tear down those barriers you talked about.
Thank you, Merida-san. Great questions. So let me give you two examples that I have always in my mind. The first, in 2023, we launched a project to improve adolescent sexual and reproductive health services in northern Vietnam. In collaboration with the international NGO, Save the Children, this initiative aims to protect health of both mothers and children. The project has created accessible visual materials and training guidelines and supports the provision of sanitary products for adolescent sexual and reproductive healthcare services. And second, in 2024, we initiated a project in which the economists involved over 75 breast cancer experts, patients, policymakers, physicians across Europe to define together ways on how to advance women-centric breast cancer care. So we are currently in the phase to present the results and to discuss how to turn the findings into action. So both projects exemplarily showcase our commitment to contributing to the sustainable development of societies globally.
And they also very much showcase the kind of multi-stakeholder collaboration that you mentioned in your opening remarks. So many thanks to you, Okuzawa-san, for hosting this event and for getting us started.
Thank you very much.
You may return to your seat. We hear next from a thought leader who throughout a very distinguished career in global health has shown unwavering commitment to empowering women. She's founding director and chair of the Global Health Center at the Graduate Institute of International and Development Studies in Geneva. She also heads the Digital Transformations for Health Lab, and she sits on the WHO World Bank Global Preparedness Monitoring Board. Her contributions to global health policy innovation were recognized by the German government with a Bundesverdienstkreuz, which she has on, a Medal of Honor. So welcome to you, Ilona Kickbush. I'm going to ask you to stand here.
Stand here?
We're going to do a little bit of rotation here, okay. So if you'd like, you can stand there, and then you have a slightly different angle for those who perhaps only saw the back of our previous speaker. And we agreed to do a little dialogue to try to create some impulses for the panel discussion that will follow. And let me start by asking you, as a global health champion and a woman, personally, what progress you think we have made in advancing women's health, and how would you assess where we stand now? And if you want to share an example or two, they're very welcome.
Well, definitely we've not come as far as we'd hoped. I mean, I've been around for a long time, and I was part of what we then called the women's health movement. And part of that was a whole range of women-led health initiatives, including a famous report, Our Bodies, Ourselves. And we were very optimistic. We thought, you know, we could move forward. And today, since I'm still around, I am very worried. I mean, we have made progress also in life expectancy. There are more women doctors. There is more knowledge on women's diseases. There are many areas. There is less maternal deaths, definitely. But there is such a rollback at present that it is incredibly worrying that for a whole number of political, ideological, patriarchal reasons, even the pure fact of mentioning women, of mentioning reproductive health, of mentioning sexual rights, will kill off a resolution in the United Nations. So one of the reasons, for example, our subject, the NCD high-level meeting statement did not make it, was because one of the statements was that NCD advice should be included in reproductive health services. And just think of that. So, you know, when we were starting off in the 1970s, 75 and so, we thought we couldn't imagine that there would be such a rollback. And I'm not even talking of the situation of women in Afghanistan or elsewhere. This is unacceptable. And I just wish we were a little bit louder about that.
And in fact, the overarching title of this year's World Health Summit talks exactly or addresses exactly this topic of geopolitical fragmentation and rollback, at least between the lines. The overarching title is Taking Responsibility for Health in a Fragmenting World. What would you say is the main challenge when it comes to translating responsibility into action in this current global setting?
Well, the main thing is the fragmentation. And, health, I say, used to be something that united us. There was, when I joined the World Health Organization, when we were working there on primary health care, universal health coverage, many of the women's issues that WHO championed together with member states, there was a feeling, no matter what the different positions were, political positions were, you could unite on health. We are now in a situation where we cannot unite on health anymore in general, but we are particularly divided on anything that is related to women's health, to their reproductive health, to women's rights in general. And we see this every day in our work. And this is really, so there is this geopolitical fragmentation, but underneath you have these other broken pieces, this other fragmentation. And of course, there is yet another fragmentation where we have divided ourselves. It is much more difficult to create solidarities because there are so many different identifications also of sexual identities, of different types of rights, etc. For us, it was easy. We said women.
Yeah.
And it is much more complicated now to create larger gender identities and solidarities together. And that also means that the individual parts can be attacked much more easily by the other side. And, it was an enormous success to be able to talk about gender and not just about sex. I mean, I'm a social scientist. This was, when we had the first professorships, on all of this. And now suddenly you're not allowed, neither to talk about sex, but, to even mention the word gender. And this is dreadful.
So let me ask you, finally, you heard our host's strong call for collaboration. What would you say are the most important ways and levers that we can use multi-stakeholder collaboration in order to try to break down these barriers to gender equity, especially in NCDs?
Well, I think from all the sectors, it's the women that should come together. What has made the difference are women-led initiatives. And we saw that in HIV/AIDS, we saw it in many of the public health initiatives around NCDs. You go to Chile, who led the tax, the sugar tax? It was women. So, if women come together from the private sector, from the media, from the community, community health workers are women. So I think the issue is maybe like we did in the 70s to literally rediscover our power and to use that power to change things not only for ourselves, but, as was said, for the benefit of society as a whole.
Professor Dr. Ilona Kickbusch, thank you very much for being here today, and thanks for those powerful messages. And we are going to now take those messages straight into our panel discussion, including your message on leadership, which is one of our key topics for our panel. So let me now ask our panelists to please join me as I introduce you, and then you can take your seats here on this stage. And I will begin by welcoming Stina Bosse. She is a member of the European Parliament and Vice Chair of the Committee on Public Health. She formerly served as Group CEO of Tryg, which is the largest Nordic insurer, and as a director on the board of Insurer Allianz. In 2010, the UN Secretary General Ban Ki-moon appointed Stina Bosse as advocate for the Millennium Development Goals. Welcome. It's wonderful to have you with us. Professor Dr. Alako Siesa is head of the NCDs management unit at the World Health Organization, providing strategic leadership, management supervision, and overall direction to WHO's work on NCDs. She previously led the WHO's work on disability and rehabilitation. She's a professor and researcher in both the UK and Germany, and has developed extensive expertise in the area of mental health. Welcome to you. Great to have you with us, with Alakos. And it's a pleasure to welcome back to the stage, because he was with us last year as well on that panel that we saw some clips from earlier, Professor Dr. Markus Kosch. He's head of oncology for Europe and Canada at Daiichi Sankyo. He's an expert in internal medicine and practiced at the University Hospital in Münster here in Germany, where he also still teaches. Welcome to you, Markus. Great to see you again. That one's for you. I'm very proud to introduce Dr. Sara Nasser. She's gynecological oncologist at the Fondazione Policlinico Universitario Agostino Gemelli in Rome, one of Europe's main cancer centers. She also serves as an executive officer for the Pan-Arabian Research Society for Gynecological Oncology, and she is chair of the Global Health Task Force for the German Cancer Society and head of Global Women's Health at Charité University Hospital here in Berlin. And it's amazing that you joined us live, given how many different places you are in at one time. Sara Nasser, please. And I'm so pleased to welcome to the stage Phoebe Ongadi. She is executive director of the Kenyan Network of Cancer Organizations, KENCO, which unites over 70 civil society organizations engaged in cancer prevention, treatment, and survivor support. With extensive experience in community and patient engagement, Phoebe also serves on multiple policy working groups and leads national advocacy initiatives grounded in equity and access. Great to have you with us. So I'd like to get started by asking all of you to share your personal perspectives on the gravity of the health gap that women face, and also what the key challenges are that you see either in your particular region or your area of work. And I am going to ask you to keep your answers fairly brief, if you would, because we want to cover a lot of ground in our panel. And Stina, at the outset, we posed this question, why are we still here talking about an inequity that has been apparent for so long? And when I was looking at some of the things that you have written and posted lately, I thought you must have posed the same question to yourself earlier this year when, together with two colleagues, you relaunched the European Parliament's Group for Women's Health. Apparently, you also say, wow, we're still here and we still need to be working on this. So what are the main barriers that concern you and that you want to tear down?
Well, I'll be very honest and tell you that when I joined the European Parliament more than just 1 year ago, I had been working for many years in different positions with the question of equality, gender equality, and I did not have a clue that the gap was as large as it is. I did not have a clue. And that's only to encourage all of us, and I will champion the gentlemen who have found their way to this audience, to encourage all of us to speak up about this. It is not out there. People are not knowledgeable enough about this question. And I mean, if I'm not completely wrong, half of the voters out there, half of the customers out there are women. Why are we not using our position to change this? And that's only, in my opinion, because we don't know enough about it. And we don't put it into the category where it actually means something to us. And for me personally, it means a lot. Just short, my youngest daughter is now 40 years old. She has endometriosis. And this was discovered, I guess, about 8 years ago or something like that. I never knew. And even when she told me about it, I didn't know what it was. I had to try and sit down and understand it. So this is, and I mean, I'm not a doctor, but I'm not unknowledgeable. So we have a lot to do about information and speaking up.
Very good. Thank you very much. That's exactly what we want to do here today, of course. So thank you for highlighting that. Alakos, you have used your public role to call attention to gender inequities in disease areas ranging from cancer to lower back pain. That's just what I found, probably others as well. So tell us more, if you would, about your perspective on why we are still here.
And look, I will also have or put a critical perspective also inwards for us at WHO, because I think we know the facts, we know the gender gap, but still we work in a very disintegrated manner. We have great initiatives and great work going on, for example, with the breast cancer initiative, with the cervical cancer initiative. We have guidelines on integration of NCDs on sexual and reproductive health. We have guidelines on diabetes and women and sickle cells during pregnancy, diabetes during pregnancy, but we don't have an overall strategy at WHO on how to address the issue in a comprehensive way and following also a life course approach. The good news, there is some good news, and as you all know, because it has been mentioned over and over again, we are going through a restructuring process, but coming out of this process, there is the strong commitment at WHO also to develop a strategy to address comprehensively women's health.
Thank you very much. In other words, reading between the lines, and we will come back to this topic in our last round of discussion today, but in some ways, the geopolitical pressures of a fragmenting world perhaps can drive the kind of integration that we need and strategic vision. Marcus, you were also, as I said, part of last year's discussion, and you highlighted a number of barriers that you see in your own work. So recap that a little bit, if you would, please, for us. And what do you see as the most persistent challenges that we face when it comes to gender inequity in NCDs?
Yeah, it's a good question. First of all, this is being the only male here in this exquisite group. This is also personal to me. I live with 3 strong women, my wife, who is a pediatrician, 2 grown-up daughters. For this is a super important topic, and they're very adamant about it, and this is very personal. And the other personal element is my professional background, having been a teaching doctor at an academic hospital. I've seen exactly what we heard earlier in this film. There's not enough female participation in trials. There's not enough education around gender-specific symptoms and diagnosis. There's not enough shared decision-making, gender-fair decision-making. And that's probably the most still persistent barrier, I would say. We had that last year, I think, where we said, look, the health gender gap is only one part. It's an important one. It's one part of the overall equity issue that we have. But I'm still positive because I believe there is a momentum. There is something growing. And that we are here again and the meeting is even bigger than it was last year speaks to the fact that we know more. And data is, and we want to know more. And data is helping, I think. We know more about epidemiology. We know more about the role of gender on diagnosis and outcome. And science is helping as well. If I look at, obviously, our area of dedication, expertise, and commitment, breast cancer. Like the biggest and most common cancer in women. In Europe, 2 million women alone die every year by breast cancer. And there is so much progress. Also since last year, we see now better overall survival. We see more more tailored approaches. But there's still a couple of remaining issues that we will probably discuss more. One is there is still not enough screening, and there's not enough uptake on screening, which is the easy solution, let's say. And especially in cervical and breast cancer, early detection is the only key to real survival and long-term success. There is not enough support for metastatic women with cancer, and there is clearly not enough understanding of financial, of work-related, of physical support for women with like cancer specifically. So the quick answer is, I think, the shared decision-making, this equity in women taking a share in policy decisions, political decisions, also their own treatment decisions, that's probably the key issue still.
Thank you very much. Sarah, tap into that very broad international experience that I described and tell us what challenges women in Europe and the Middle East share and where they diverge, if you would.
Thank you very much for this question. And I want to tap in directly to what you said, the shared decision-making. And let me tell you, it's not easy, and it's a problem whether it's in Europe or the Middle East or North Africa region. So it's the same problem. Why are we still here? Because we might be good at documenting, and maybe in Europe we're better at documenting than in some regions in the Middle East and North Africa, but we're still not good enough at listening to the women, and we're also not good enough at implementing what we actually know. So it's not exactly a crisis of there's a lack of innovation or a lack of science, because we're making amazing progress with that. It's more a lack of actually implementing and getting that innovation and that science exactly where it's needed most. And this is, I think, the difference, and that's the main barrier. It's a barrier of implementation and listening. So I have two examples. A lady with endometriosis, you mentioned endometriosis. Maybe take a guess at how long a lady has to suffer before she actually gets diagnosed with endometriosis. You're very close. 10 days, 10 months, 10 years? Yes, it's actually 8 years. So before somebody says, yes, you have endometriosis, and there are multimodal treatment plans for endometriosis, which work, but 8 years have to pass before she gets a diagnosis. And this is exactly the same, whether in Europe or the Middle East and North Africa. So this is important. This should not happen. Why does a lady need to be in pain for so many years before we actually listen to her? And this is from a perspective of a gynecologist and a surgeon. And then the other example is, for example, I had one example written down, what you said about the decision-making. So we have multidisciplinary tumor boards where we actually sit experts globally and discuss about cancer cases, breast cancer, cervical cancer cases, Middle East, North Africa, Europe, and the United States as well, experts all over the world. And we have a lady with ovarian cancer who could benefit from ADC therapy or immunotherapy, actually improves her survival by 2.5 years. So we know that if they get that therapy, they live 2.5 years longer than if they didn't. But if she doesn't live in the right country or the right region, she doesn't get that therapy. Mm-hmm. So we shorten her lifespan by 2.5 years. So that's just...
Thank you very much. We'll drill deeper on those examples and others like them a little bit later on. Phoebe, as I mentioned in introducing you, your civil society engagement does bring you into very close contact with community groups and also with vulnerable patients. So what are the main barriers that women face when it comes to cancer in Kenya, from your own experience?
Thank you very much for that question. I come from a country where we are over 50 million people, and as of 2025, it was recording 60 million. Slightly half of those are women. The main barrier to women in my country, and I believe other African countries, is called an enemy called delay. Women often face delay in treatment, delay in diagnosis, delay in policy decisions, delay in access. So all these delay barriers is what is causing us problems. When you look at our statistics, for example, the non-communicable diseases are killing 41% of our community every year. it is also causing more than half of hospital admissions. Now, here is where the problem is. 60% of those deaths squarely fall on the woman. And if you look at the leading cancers that are killing women in my country, they are women cancers. Only women have a cervix. Cervical cancer is the leading cause of death among the cancer deaths in my country. And yet, this is a cancer that can be treated, can be prevented with curative agenda, and can be totally eliminated. Again, the problem of delay. We have breast cancer also causing 1 of 4 female cancer deaths. Breast can easily be detected early, can easily be treated. So if we bridge the gap of awareness and implementation, because right now awareness is there. People know I need to go for screening. People know I need to have my breast checked. But there is this woman who shows up or has to walk 200 kilometers to a facility that is far away. The access gap is a barrier. They know they should get it, but how do they get it is the problem. In my country, the burden of non-communicable diseases is on the woman, and constantly women are held up to choose between giving nutritious foods to the family or medication. For a man, they will easily choose medication and walk away, but the woman has to grapple. Am I going to get money out of my pocket to treat diabetes, to treat cancer, and watch my children die? Or am I going to be bankrupt for me to to buy the medication that I need? So the issue of access and linking the awareness and access, and if we are able to halt down delay, then the African woman will not have to bear the burden of non-communicable diseases.
Thank you very much, Phoebe. And you have just named several of the problems that we will see now in our next film. It illustrates the barriers and the burdens across multiple regions, and the fact that NCDs do, in fact, affect 2 out of 3 women worldwide. Let's take a look at that film.
43 million lives lost every year. This makes non-communicable diseases the most common cause of death. 2/3 of women die from NCDs, largely underdiagnosed and undertreated. Poverty is the underlying cause in many countries, countries where a woman's well-being and treatment take a back seat. 8 of 10 premature deaths from NCDs occur in these low and middle-income countries, and a woman's chance of dying from such a disease before the age of 70 is far higher in the global south than in the north. Solving this doesn't take a miracle. €1 per person per year could buy basic services that would not only save millions of lives, women and men, but also return billions to the global economy. In wealthier nations, it seems awareness is needed as much as money. Take the most common cancer, which affects almost only women. In Europe, for example, the number of yearly new cases is expected to rise, partly because fewer women go to screenings. Also, across the continent, over half of new medicines are unavailable to patients, and if they are, access can take up to 2 years. Systems adapt slowly. As a breast cancer patient, you don't have time to wait. Add to this the hidden effects of NCDs on women. Many see their income drop after a cancer diagnosis, and when a woman falls ill, often a mother, a wife, a caregiver falls ill. So lifting the NCD burden for women keeps society healthy.
Yes, we can applaud for that film, I'd say. A powerful illustration that picks up on the points that basically all of you made in your initial remarks there. Let's come back to a couple of those different aspects and talk also about what better care, what improving care would mean for women on the ground in the regions and the areas that you work in. So I'll start with the poverty issue, if I may, and both of you mentioned that, Sarah and Phoebe. So maybe starting with Sarah, it clearly is a root cause of gender inequities in many places in the global south. How do you deal with that in your own work? What can and must be done to fight the pernicious effects of structural economic inequality? And do you also have perhaps a couple of examples you could share there?
feel like I keep going back to Marcus because shared decision making and actually building the bridges. So what we see, I've already started giving that example. We have these multidisciplinary tumor boards, which are these meetings that are virtual, where we sit with clinicians, immunologists, pathologists, so scientists from the Middle East and North Africa region, and they present cases to us where they need a second opinion from someone about treatment, about diagnosis, etc. And then we do get cases like that where we would say, well, the European guidelines say that you need to give this immunotherapy. And then they say, we don't have it here, there is no access to it here. So what do we do? And what we've done within a level, and you go on to the meta level, so that's when you need the societies on board, that's when you need the international collaboration, and I know we will go on to that next, because that's how you actually, what we've done then is, with the European Society for Women's Cancers, we've developed a research stratified guideline for women with cervical cancer to be used in low and middle income regions, but also during crisis situations where, for example, some treatments may not be available for 6 months or for a year or even for longer. And so what is the next best solution that we can recommend? And it was not easy. We worked for 2 years on this guideline and only for one type of cancer, which is cervical cancer, which is actually also a very preventable cancer. So going back onto the problem of access. But this is really what we need to do. So it's being aware of the problem, making it visible, because that's the second thing, in an international, global level, and then actually trying to solve it and implement something that is adaptable for the region.
And let me go to Phoebe. You cited a couple of ways that poverty and structural inequality play out in impeding women's chances to get both screening and treatment. What solutions are you seeing in practice on the ground to try to address that?
Thank you very much. One of the solutions is for priority, because the statistics that we are seeing now is as a result of our priorities. For a long time, we have not prioritized the women in NCDs. So we need to prioritize the health of the women in NCDs and ensure that the awareness and the prevention and the innovations is localized. For example, we can rewrite those statistics if only the care came closer, if there was equity, and if there was a faster diagnosis. So one of the reasons is to localize. And then we need to have more women involvement into high-level health policy decision-making. My country has less than 30%, and that happens across most of African countries. You discuss women without the women, it cannot work. They are the ones who walk the distance to go for clinic and healthcare. They understand better. And anytime you improve health services of any country, you improve the life of the women, because they are the ones who bear the burden. We can rewrite that story by our priority. We have prioritized, and it now affecting us. We can reprioritize now and bring it closer to the woman and have the woman involved through their lived experience, through their community involvement, so that we have improved. So having localized prevention, having localized innovation, and making it work can improve those statistics.
Thank you very much. Alarcos, do you also want to weigh in on the aspects of structural inequality in the global south and how we can address that?
I think I was actually, when I was listening to you, I was reflecting also on the data that was presented yesterday from the Global Burden of Disease 2023, where one of the clear messages was in Sub-Saharan Africa and in South Asia, women are dying earlier than men, and significantly earlier than men, and of course very much driven by cardiovascular diseases, but we cannot forget the rapid and accelerated increase on diabetes and kidney diseases. And I think that is still not in the minds of many public health leaders, that really these inequalities, especially in those areas of the world where the transition from communicable diseases to non-communicable diseases is really accelerating speedily currently, that we need to pay attention to. We target these approaches in those specific issues. One beautiful example is what India is doing in its national hypertension initiative, that is a multi-sectorial collaboration with, under the leadership of the Ministry of Health and Family and Ministry of Health and Family, Resolve to Save Lives, WHO, but also civil society, where even if it is about achieving hypertension control in the whole population, specific strategies are being implemented to reach women, and also not only for hypertension screening, but also integrating cervical cancer screening, where register volunteers then go and do outreach approaches in order also to reach women in rural areas.
Thank you very much. And what you just said underlines the importance also of data. And
Absolutely.
one thing that we talked about last year is the actual lack of disaggregated data on big disease areas, so that we truly understand the differences between how these affect men and women. And I think we all know that standard example of heart attack symptoms being very different in women, and many women being unaware of what it looks like in the female variant. So data is clearly extremely important. And Stina, I know that that was part of what drove the reestablishment of the European Parliamentary Group, was awareness of that. So talk to us a little bit about that aspect, if you would, and then I have another question as well for you.
Well, I guess, I mean, and this is back to what is actually, in the times we're living in, what is actually going and what is not going. And unfortunately, knowledge, knowing, and using our knowledge is sort of trickling down. It's like, you know, oh, this is so boring, academia, they're boring, and this is, you know, terrible. Even in the Sant Committee, in the European Parliament, we, in each and every meeting, we hear from some politicians the following: well, we all know that COVID was invented by the industry. They say this as if it was knowledge. This is ridiculous. And I would just encourage each and everybody in this room who are, I'm sure, very knowledgeable, speak up. Data, knowledge, knowing is, you know, at the core of solving some of these issues. And we should not let ourselves be fooled by people who don't want to acknowledge knowledge and data.
So there's the distortion of knowledge and data that you just mentioned, but you also said when you launched that women's health group that just 4% of what's happening in research globally is actually directed to women's health.
Yes.
That number staggered. I was really confounded by that.
But this is, of course, also, mind-blowing. And that was also why I was, when I saw all these data points, I thought, with this, really, we need to do something about this. And to make sure that we address this is not going to be easy, because I do very much agree with what the professor also alluded to. This is as if, you know, we are living in times where talking about these issues is not, how can I put it, it's not modern, which is ridiculous. It's as if, you know, we've solved it, we've done it. It's all, you know, let's forget about gender equality. We've been there. It's gone. It's solved. And knowing all this, and knowing that we are not close, is sometimes making people like me, and I guess some of you also, a little bit desperate. And you know what? We need to be desperate about it, and we need to be vocal about it and say, no way can this go down on our agenda, because we are not there yet.
Marcus, I was also very surprised to see in the film that there has been a drop-off in Europe in women getting necessary screenings. Again, how is that possible in 2025, where all of us know about the need for and effectiveness of early screening?
Yeah, you're absolutely right, and this is frustrating, I would say, and that's an area where we don't get better or haven't seen progress since we met last year. It's, yeah, you say it, we all hopefully you know it, screening, early detection for cervical, for breast cancer is key. It's the absolute foundation of long-term outcome improvement. But also in Europe, where access is not even the key challenge in most countries, only 8, I think, of all European countries meet this not super ambitious 70% screening target. So we are not yet there, and you're right, the numbers decline. There is probably not the one reason that we could easily fix. It's a mixture. It's still the pandemic, I think, hesitancy to see a doctor, to become part of the system. Partly, and probably mostly, it's misinformation or a perceived overload in information. And it's, again, the ones that are affected most, the caregivers, the patients themselves, are not enough listened to. They are not enough part of those policy builds. So what we have been doing since last year is a small step, not the magic bullet, is facing this information gap, I would say, because in focusing on nurses specifically, we've rolled out a nurse education program because, yeah, you know, most nurses are women, and they are also probably the most important individual factor for the treatment journey, the treatment experience of a woman. They are the first, the most frequent, the last a female patient sees. So we instill information, decision-making, education focuses a lot on the often still male physician. So we have rolled out a nurse program, educating them specifically with huge success, I think, so far. And not only on medical information, it's also about communication, how you counsel your patient on side effects, on also sexual alterations you see with treatments, on how their role as a mother, as a partner changes. And I think empowering them might be a key measure actually to improve the overall outcome for women with those diseases. Not a magic bullet, but one step that we can contribute.
Stina, did you want to speak to that? I hear you nodding, or I don't hear you nodding, I see you nodding.
Well, it's just I'm very passionate about getting more knowledge out there. And in this area, in other areas, and all the nationalistic tendencies that we see, crossing, obviously, what I heard you saying also, that, you know, new knowledge is generated cross-border, and we get so much wiser when we work together, and we can actually solve problems. I asked a lot of people, parents to children with rare diseases, also parents who would probably, you know, be a little bit nationalistic in the way that they saw the world, and then I asked them, you know, what if I could show you a place, not in Denmark, but in Madrid or in Rome, somewhere, where we could take your child and have this problem? I would go immediately, they said. So if we get this new way of thinking across to the citizens in Europe, globally also, that should be our ambition. We could do so much more.
Knowledge is so important. Just one interesting data point, since you mentioned data. Did you know that as a woman, your probability of surviving a heart attack is 30% higher if your emergency doctor is a woman? 30%, that is hard data, right? And simply because there is too little understanding of female-specific symptoms of heart attacks. It's not access, it's not bad intent. Actually, doctors don't know. So knowledge, education is really key.
Yeah. However, I would say, even if I completely agree that knowledge is absolutely fundamental, but that puts, I think, the responsibility, it seems to put the responsibility much more in the individuals. When we know and it is the typical message that we give over and over again, but it is important, is really political leadership, also what makes things change.
And
so if we think, for example, of cervical cancer, the only low and middle income countries that has achieved the three targets, there is only one middle-income country, low-income country that has achieved the three targets of the Cervical Cancer Initiative, and that is Bhutan. That was because of the political leadership, no other country apart from high-income countries. So I think knowledge is important, but
and that's where we're going in our third round of discussion. But before we go there, well, Sarah, you want to say something, please? And then I want to ask about mental health, but please, go ahead.
Okay, perfect. So I just wanted to say directly to that, there is also a study about female surgeons operating on women with gynecological disorders. They tend to have better outcome if the surgeon is a female. So similar set of data there as well. And what we've all mentioned is one of the things is, for example, when you said about knowledge and awareness and listening to the woman. So there's an initiative which is doing really, really well in Egypt. It's called the Presidential Elective Initiative about bringing vaccinations, HPV vaccination into Egypt. And it's going very, very well. But there is a group where they were left with 30,000 vaccines that were not being taken up. So in that, the resource was there, the vaccines were there, they were available, the community workers were there, but they were just not, the people were not coming to get the vaccines. And one of the solutions to that was actually getting the religious leaders involved, because obviously that is a big area and a big point to focus on, and getting the religious leaders to say, if you have this vaccine, this is, you know, you're going to actually protect your daughters from cervical cancer and infections. And so this is an important point of view when we're talking about listening to not just the women as patients, but also the women leading the initiatives.
Yeah, thank you very much. Let me just briefly, if I may, ask Phoebe to talk about something that certainly in higher income countries, we're very aware that many cancer patients are dealing with very big mental health issues that deserve their own treatment as well. And I'm sure that patients in your country are no different. But to what extent is that recognized and actually addressed within a health system like Kenya's? And what can you do about it in your outreach to vulnerable patients?
Thank you very much. At KENCO, we like what we call data-driven advocacy. When recently we were pushing for mental health, and we realized that most data report that 1 out of 5 caregivers of a cancer patient at any one time go through depression, anxiety, those symptoms of mental health. So if 1 out of 5 caregiver will go through that, then it means 5 out of 5 patients will eventually go through depression, anxiety. I'd like to take you back to the African scenario. We come from a country where women are told to normalize pain. They are told to normalize extreme conditions. They are told to normalize things like mental health and all that. So for us, it is a new thing. Mental health, most of the times in our facilities, it is handled at the last. Yet we know in most developed countries, mental health is handled at the diagnostics. So we are slowly moving there, and we are slowly convincing them that a woman is no much difference. Because this thing of normalizing pain, this thing of normalizing all this is what is causing us to have these adverse statistics. They will normalize a bleeding, and they will say it's menopause, you're growing, and they will not want to share with their husband, because the men in Africa know how to run away very quickly if there's a problem with the disease, especially if it is the woman. I don't know why the women stay if it's the man who is unwell, but the moment the woman is vulnerable and gets unwell, they will run away. Love to all the African men in the room. So then, it is an area that we are slowly, but eventually coming into, but it is a new area because women are taught to normalize all these adverse effects. But we hope that even as we go on, mental health will be given the attention that it deserves. Not just the woman, but even the household, the caregivers. They also need the mental health. And not just the caregivers, also the healthcare workers that take care, because the cancer burden in Kenya is big. So it means the healthcare workers get burnout, they get depression and anxiety. And a burnout healthcare worker is not a very good one. So you need a healthcare worker who is healthy, who is calm, for them to bring out the outcome that is required from the patients.
Thank you very much. And of course, normalization for pain is very much what's behind that endometriosis statistic that you mentioned. Oh, it's just normal period pain. Yeah. Yeah, yeah. Alakos, I know you're a mental health expert. Do you want to say anything about underdiagnosis and treatment of mental health in terms of also gender disparities? It's not your current role at WHO.
Yeah, it's not my current role, but look, gender disparities are high, and I think, again, what we see in the data, that we need to pay attention a lot to younger girls in terms of the increased statistics and increased prevalence in terms of depression and anxiety, also related, as an hypothesis, to the increased use of social media and what social media does with us and with societies. So it's one of the critical periods also in the health journey of a woman, the adolescence, and I think it's something to pay attention to in terms of the consequences and how we address this properly.
Thank you. Very interesting point. Body shaming, for example, via social media. Let's go now to a deeper dive on collaboration. And as you'll remember, the overarching topic of this year's World Health Summit is taking responsibility for health in a fragmenting world. And we have a third film that picks up on exactly that theme, with a reminder that while progress has been made in line with major commitments at various international gatherings and institutions over the years, that effort is now facing headwinds long before the key goals have been reached.
In the past 10 years, female NCD mortality rates have fallen. Also, maternal mortality has declined. And more women have taken on leadership roles globally. Good news, right? Progress in women's health is slow, but the world is working on it. With the UN Sustainable Development Goals,
they carry the hopes of people everywhere.
That include breaking gender-based health barriers. The EU has drawn up a roadmap for women's rights, with women's health as a central pillar.
As a woman, this means a lot to me.
But there is pushback. Many countries have cut their foreign aid, impacting healthcare for millions of women. And funding is only part of the headwind. In a political climate in which common ideals are questioned, the lack of will hurts more than the lack of means. If the health gap is seen as irrelevant, and words like women and gender are getting banned, will this slow down progress, research, and the momentum that the world had?
It's incredible that we're even sitting here today, 2024, and discussing this matter. We need a plan.
Now it's 2025. Where is the plan?
Let's talk about what would be your plan, what you see as most important to ensure that we do take responsibility and make real progress on this issue. And there are a couple of different things we've talked about in the discussion. I'd like to ask you to try to tie those together into one key answer so that we can open for audience questions pretty soon. So for me, those aspects would be that multi-stakeholder collaboration that all of you have mentioned in different ways, and then leadership. And maybe you can address that or other points that you think are crucial to having a plan that really works to get changes to the women who need them. And I'm just going to go straight across the panel, starting with Stina.
Well, first of all, I think if I think of where I could start, and sometimes it's easier to go like this because we always go like that. I mean, I can and I will start with some of the legislation that we're sitting with right now. It's the pharma legislation, it's the Biotech Act, it's many of these pieces of legislation, it's the next MFF. In all these areas, we can actually make a difference. And we can make sure that some of the subjects that we're talking about here actually trickle into this. Even if it's going to be a harder struggle than it used to be, it should not make us stop. It should not silence us. We should still speak up on these issues. And we should make sure that we all understand that if we don't put into the next MFF a prioritization,
multi-year financing framework.
Exactly, for Europe. If we don't, though, for the EU, if we don't do this, we will never get anywhere in these areas, because there are some basic things in the research area where we need also public money. On top of that, of course, we need businesses, like we heard about, and thank you very much for speaking up in this area. Businesses, on top of that, also investing. And here again, I just want to reiterate, women are half of the citizens, half of the voters. Women are half of the consumers. This position has to turn into changing this whole area.
Can I just ask you very briefly, Stina, if you would? We're hearing a lot of talk about how to revive innovation in Europe. And as we know, on health, in recent years, it's been lagging. Fewer clinical trials conducted in Europe, delays in drug approvals in Europe. Can Europe step up to the plate as a global leader on innovation when other countries are perhaps not necessarily going to be taking that role anymore?
Thank you so much for that question, because that goes directly into my point of, who we are as women. I could picture quite a lot of my colleague MEPs who would say, oh, we can't come up with this subject now. For example, we cannot demand in our legislation that females should be represented equally in clinical trials. That's too complicated. We are into simplifying now. I would say, but that's ridiculous. This is what should benefit the European Union, is that we actually take into consideration and take seriously this fact, because that goes into the marketing. That goes into the marketing budgets 5 minutes later. So if you buy a product from the European Union, developed in the European Union, it is also gender balanced, and it is also tested equally on men and women. Why are we not seeing this as a positive? And this is the political fight, exactly where it is.
So Alarcos, the film mentioned funding cutbacks, and certainly the WHO is now facing cutbacks. And as you mentioned very diplomatically in your first answer, redirecting resources and looking toward how you can mobilize nonetheless. Tell us, who are the most important allies for you now? What are the partnerships that will be most important going forward for the WHO?
So what I would say, however, in terms of financing and health financing NCDs, chronic diseases, I think we need to really look and facilitate the work in countries on domestic financing, and really look from the perspective of domestic financing to address the NCD really transition that has happened already in our all health systems, and that has provoked and caused the absolutely increased need for care and for interventions to address NCDs. I think there is a need to look also inwards and not so much to look outwards to external sources of financing.
Mm-hmm. And what about leadership? Do you still see the WHO in a role to play the kind of leadership or to shape the global agenda going forward, despite the pressures?
Absolutely. Look, absolutely, and I think we are, as all of you know, a member states-driven and guided organization. We have obtained tremendous support from our member states. We have got approved a 50% increase of our financial support from countries to WHO. So the commitment from member states is there, and from the majority of member states, absolutely.
Thank you very much. Marcos, looking toward the future, multi-stakeholder collaboration, leadership, where do you think the top priorities are to be sure that we won't be sitting here 10 years from now still talking about the same subject?
No, hopefully not. 10 years is a long time. Look, as I said initially, I think there is a momentum and there is a couple of things that make me hopeful that we move in the right direction. Stina, the interesting group in female health or women's health that you have started with other MPs is an important step. The upcoming roadmap for women's rights that the EU is promoting is a step in the right direction, I would say. So there are plans. We just need to accelerate them. We need to push them. The three key areas, since you asked, that I think we should focus. One is really screening and early detection, especially in cancers that are female-specific. And that might have not been the priority they deserve to be because of that, actually. Make sure these programs exist, they're accessible, equitable, and get the attention they need. The second one is equitable access to innovation, to medication, to treatment, specifically for women, typical or for diseases that are most biased by gender. That's important. And often it's male making those decisions, right? And I'm not sure that is a bias, but we should make sure it's not becoming a bias in that regard. And finally, Pernilla said that we need a plan. We do have a couple of plans that I think could become even stronger. The European Beating Cancer Plan, let's make sure it has a focus on gender bias and gender pay gap. Because that plan exists, it's funded, it's supported. Let's make sure it takes that into a specific focus. The upcoming cardiovascular action plan as well. Let's make sure there is a focus on gender gaps also on cardiovascular diseases. I think if we use the tools and the plans we have more together, collaborative, we can achieve a lot before 10 years, hopefully.
Thank you. Sarah?
Yes, so I would like to start with maybe the same as Estina, so from myself and then from the multi-stakeholder collaboration. So definitely there is a positive momentum right now. And what we're working on is a code of conduct on including gender bias and how to eliminate gender bias in clinical trials within the gynae cancer societies. So this is something that we're working on right now as a code of conduct. It cannot be a contract, it is complicated, as you said, but it can be a code of conduct that one can be proud of to say we were able to adhere to this code of conduct. Because definitely women in clinical trials are really neglected, and not just women as a gender, but also in terms of ethnicity and diversity. So this is what we're working on from a gynae cancer society. Really, we need to be accountable and we need to have the right people around the table. So women-led initiatives is key in getting these international multi-stakeholder collaborations. So for example, getting patients into our meetings and into designing clinical trials. This is very innovative, so getting patient advocates. Obviously in gynecology, they are female, so they actually now have a role in designing the clinical trials that we then implement, and also they participate in our tumor boards. So this is, again, a type of multi-stakeholder collaboration. And then adding on to what you mentioned, the big collaborative groups, we're also, I want to add the UNFPA and the WomenX Collective, which again is a collective gathering all the international societies to actually impact and improve women's health, and really drive back the message that investing in women's health is probably the smartest investment we can make, and it's not just charity, it's actually quite a smart economic decision.
Precisely because of all those multiple roles that women do play, you get a big multiplier effect if you keep them healthy.
Absolutely.
Phoebe, please, last word to you for this round.
Thank you very much. When you look at our country, we have been the most affected by whatever is happening around funding. By the time we finish this meeting tomorrow, the next day, we will have lost 10 women to cervical cancer. Previously, it was around 8, but it's increasing because of that. And just 2 days before I came here, we were in the streets of Nairobi we carried a petition to Kenyan Parliament, and we were telling them it is high time the country prioritizes cancer. Because if you look at our statistics, number 3, the 2 and 3 leading causes of death is NCDs and cancer. And yet they get just less than 5% of the national health budget. We are carrying the burden of NCDs in a country that has for a long time looked at the infectious illnesses. And the reason why I'm saying we are the most affected, it's because with the donor funding and all the help, the immunosuppressed women will get what we call yearly screening. And that's why now we are changing our trajectory back to look at the girl, the 10 to 15 years old, and how can we save their future? And we are lucky that our government recently rolled out the single-dose vaccine. But we are going back to tell them, why are you delaying? Because they're telling us we have to call multi-stakeholder meetings, we have to do trainings, we have to call this. But thereby, as they do that, this girl who is eligible for this vaccine will soon turn 16. The girl that should have gotten the free treatment and the free whatever will have turned 16. And then this girl also will be in the hands of a pastoralist somewhere who is already counting the number of cows that this girl can bring in form of bride price. So for us, waiting is not an option. We are now going backwards to ensure that single-dose vaccine is quickly rolled out, and we will keep knocking the doors, because we went to Parliament and we were able to get through. They read out our petition, and we told them that reducing the cancer budgetary allocation for the country by almost 70% will put more pressure on the woman. Because as we said when we started, it's the woman who always has to choose between food and medication. And that shouldn't be the case, because equity for women in Africa is not charity. It is their right.
Thank you so much for that very eloquent summary of the challenges, but also of what community engagement and grassroots pressure can achieve, hopefully. So let us now take audience questions, and I'm going to rotate in my seat. Yes, we have one here. Can we get a microphone? Here's 2 more. So let's get a mic over here and maybe bundle these 3. Starting here with this young lady.
Okay, thank you. My name is Samuela. I'm from Ghana, and I'm a biomedical engineer with more focus on medical imaging for women's health particularly. So I found this conversation very insightful, but I have one thing. I feel like we talk about this a lot. Every single time we talk, but where is the action? There's no action. And so I loved when Phoebe said we have to bridge the gap with the talking, with the knowledge, and the implementation. We have to do the implementation. What exactly are we doing? Everyone keeps talking about the fact that, yes, we have the knowledge gap. At this point, everyone knows about breast cancer. Everyone knows that you need the early screening. And Melinda asked the question, why aren't people actually going for the screening? Because no one is listening to women. I'm working on a project for an imaging device for cervical cancer screening. And the thing is, for a device like the speculum, which was designed or created in the 18s, nothing has been done about such a device, which is one of the most important devices when it comes to women's health. But no innovation has been done. When it comes to something as low as a bandage, it's been evolved over the years. But
of ableism as well. So from your last question, what's the plan? How are we including women and girls with disabilities in women's health? And my second question, it's about menopause. We know also the impact of menopause in women's health, in productivity, in well-being, and the risk of NCDs. And yet, it's one of the least prioritized. It's mostly about reproductive health. So what happens to women's health after reproductive age?
Thank you very much. We're going to keep those 2 in mind, and you can pass the mic to the lady next to you. Please, go ahead.
Okay. Thank you so much for that question. It really aligns with what I was also going to say. First of all, thank you so much for a lovely conversation and the discussion on women's health. I really wanted to talk about the language that we use and how we really focus on women's health and it's oftentimes in the face of the child or the husband. And if we go back to the second film that we watched as well, the highlight towards the end focused on how we play the role of a caregiver, a mother, or a daughter. And that again tells me that my health is not as important, but it's more important because I am a caregiver and I have a family. How important it is to just have my health focused on as a woman instead of a mother, instead of a caregiver.
Okay. Interesting. Yeah. Yeah. No utilitarian reductionism.
Yes, and again, that going back to my own experience while growing up in childhood when I had the textbook first time studying about menstruation. I remember it was 2 paragraphs, this tiny on menstruation. They gave a quick picture and that was it, and you had to do a home study on that. And turned back into my master's in US hoping that I'll have more information. I did not, because when I studied developmental psychology, everything was focused on children. When the women were again focused on, it was about emptiness syndrome, but nothing about, let's say, postpartum. What happens when you do give birth and the birth trauma? What happens when you do give the child out? After that, what is happening to your mental health? Everything is really focused on when you're carrying the baby, but not right after what you are going through. So I really want to focus on the question of how can we bridge that gap on women's health by focusing on women and coming back to menopause as well.
Yeah. Thank you very much. So let's get a really quick reaction. Stina wanted to say something, and I will also ask Allocate to talk about disability, perhaps, since that was your earlier hat that you wore. Please.
No, just very fast. Go and start a business. You've got the idea, and that's where the action needs to happen. I'm sorry, now I'm only a policymaker, so I can put up the frameworks, but you have seen an issue, go and do it. There is an audience, there is a customer base. And for you, you don't know this, but one of my closest friends on X, you know, I really have a person that I've been close to, and I've met her several times. She also uses a wheelchair. She's a wonderful person, and she keeps me really on that. So I cannot have any opinion without having that angle. And that should be the case. We should not forget that there are, I mean, men and women, and then there's everything in between, and then there's everything underneath and besides and so on, and that's how we should think. So sometimes when we have these discussions, it becomes too much black and white. So I really just want to thank you for that comment.
Thank you.
And then just finally on that one, you were so spot on, and thank you very much for raising exactly that question. We are also caretakers, but we are also human beings.
Thank you. Sure. Or I was going to just ask Allocate briefly to talk a bit.
Just very briefly, of course, intersectionality issues are absolutely fundamental. We know it is extremely challenging to create the awareness, the need, especially in terms of disability. So it is, again, about knowledge, awareness, and political leadership. That is what works. And look, a life course approach we need to think from a life course approach perspective. We have talked too little about that, but I think it's one of the words that probably we can put in your list.
Thank you. So, sure. Right, we'll go right across.
I'll be quick, I promise, Melissa. And thanks for the call to action. I totally agree. The truth is in the doing, not in the talking, 100%. I wouldn't say there's no doing. We do have plans. We have also on the political side initiatives. As a company, we have this patient centricity paradigm. We do have patients inputting in our protocols. And I believe it's not charity. The protocols get better by this. We aim for equal recruitment and balanced participation in trials. And then it becomes always personal when it is about leadership and equity in broader. In my leadership team, 50% are women. And it's probably, no, I'll be careful now, but it's 50% actually, which is the ratio it should have. Can we do better? For sure. But I wouldn't agree that there has been no action over the last year. It's not enough, and we need to accelerate this, but I think we can do a lot.
Thank you. Sarah.
Yeah, thank you very much. So just again, thank you for the call to action. And I really like that. So you should get angry, and you should get aggressive, and you should get loud. Most of the femtech businesses that were founded by women who just got angry and had enough and said, right, okay, I'm not going to wait for technology to come to me and work for me. I'm doing my own thing because I know what's best for me. And to the thing about the speculum, so we got angry as well in surgery because surgical instruments are not designed for female surgeons. So we struggle a lot as female surgeons to actually handle the instruments, to be able to actually operate well. And we're now in discussion, we're publishing this paper, we're now in discussion with industry and the designers and manufacturers of surgical instruments to try and change that. So come talk to me after this, because this is really what it's all about. It's about getting angry and saying, I'm not going to wait around. And it's this what I meant about women-led initiatives, because we know what we need, really.
Thank you.
And can I just very briefly, just comment on her question?
So we also had the menopause issue. I don't think anybody addressed...
Menopause.
Yeah.
Yes, maybe I will address that kind of. So I really like both of you that you actually said we need to break free of the stigma that women are always associated with reproductive health and motherhood or fertility. Certainly important issues, but actually there are two extremes on either side. So the elderly patients, elderly women, menopause and old age as well, and then the young women who get neglected, the adolescents, and also the teenagers, etc., who also have problems. So for example, with breast cancer screening, the younger women who get abnormal breast results, there is nothing for them, okay? And we are working with some projects that can actually meet that need. And in terms of women with disabilities, I think you're absolutely spot on with that. I can tell you that in Italy, there's a project we've opened 6 months ago, the first outpatient gynecology clinic for women with disabilities, because we need more time as gynecologists to actually cater to the needs of women with disabilities. You can't see women in 10 minutes as you would normally do in the clinics. Obviously, there are some things happening. They're individual, so it's about bringing them to the global scale and actually scaling them up to reach more women and exactly where they're needed. So thank you very much for both of your comments.
Thank you very much. I think we could fit in one more question. Pardon? A gentleman, yes, and I see a hand going up over here too. So can we fit in 1.5 more questions? We're going to keep it super short. Let's get a mic over here because he has been waiting for a while. And again, we will bundle these two and that'll be that.
Thank you very much. I'm Eugene Dodoy, consultant psychiatrist and Acting Chief Executive for Mental Health Authority in Ghana again. Yeah, and thank you for acknowledging mental health, although briefly, in the context of cancer and other NCDs. And I was very happy. I was going to raise that point about women being the caregivers. And in mental health, we are very now concerned about caregiver burden. So when we talk about caregiver burden, the women are responsible again. And my question is that how do we move from mention of mental health when we talk about NCDs to meaningful integration so that mental health is not treated just as an add-on, but as a core pillar of women's care with dedicated resources, measurable outcomes, and investment equal to physical health. In Ghana, we are already advancing this through Mental Health Authority, through maternal mental health care, slightly to reproductive health of the woman. But how can global partners help scale this approach across Africa and other lower and middle-income countries?
Thank you very much. Wonderful question. Let me just get the mic over here to this young lady. Raise your hand high, please, so they see you. And I'm afraid that's all we'll have time for.
Thank you so much. So I'm Stephanie from City Cancer Challenge. Very happy to see Phoebe from Kenko in the panel. Yes, very great. So my question is, and Phoebe, you've been part of this. We are, as my colleague said, trying to move from talking to implementation. So we are trying to land down the Lancet Commission of Cancer, Women and Power, which brought a lot of recommendations to lend it to the cities that we work. So my question is like, how do we scale up the knowledge that we are generating? Since we have so many fragmented initiatives, how do we put all of them together from the cities, from the ground up, from our perspective? This is where we start. So thank you.
Thank you. Great. Phoebe, I'll let you get a start on those.
Thank you very much for the question, especially for the gentleman for standing up to ask. So I'll just answer because my country and your country are similar. One of the areas that we are strengthening mental health is awareness. For us, we have a hospital called Madare Mental Hospital. Anytime you mention mental health, they think of the extreme, crazy. So we are doing a lot of awareness, and then we are also in communication with the curriculum developers, especially of the medical training schools, to give mental health. Usually in the medical schools and nursing schools, mental health is just mentioned as a unit, but we want it to be given the good attention that it deserves in that, so that there is, as the students come out for practice, they already have the knowledge, book knowledge, then they come and do the practice knowledge. So I would say awareness first of all, and then this awareness should start at the point of diagnosis. When the biopsy is being taken, when the tissue is being taken, mental health should start from there, not only for the patient who has gone for help, but even the person who has accompanied the patient to there. So they need to know that at every given point, from screening to survivorship, and sometimes even up to the end of life care, it should be a continuous process. In Africa, it is very new, but with time, communicating about it, talking about it, we can actually put it up and ensure that mental health is normalized. Mental health does not mean you're crazy. It only means you're aware of your feelings and you're taking care of that so that you have better outcome in cancer. So start with awareness and to ensure that those outcomes are better. Here in Europe, mental health is the normal thing. So I understand your language. For us, it's a bit different. For here, it's different. So yeah, so awareness start first of all. Thank you.
Thank you. Does anybody want to weigh in on the very last question about how we scale up from bottom up, I think was your question. Anybody have a thought on that? Please, Stina.
No, I just think, I mean, we're back to where we started. It's all about keeping up the speed of talking about this, keeping up the awareness of there is an issue. And then I just wanted to react also to Phoebe's, I mean, I'm sorry, but it's also an issue in Europe. It really is an issue in Europe. Mental health is still, you know, we don't really talk about it. It's a little bit, if there's something mental, it's not really something we talk. So on all these issues that we've touched upon today, let's keep up the conversation globally. Yeah. And let's make sure that we, as policymakers, come to the right decisions on framework.
And by the way, speaking of things we don't talk about, Ilona actually asked me to mention, but she's gone now, I'm sorry to say, and I'm going to mention it anyway, violence against women also as a topic we speak about far too little, and it is, of course, directly related to mental health. Do you want to speak to it?
I just want to tie the violence against women to the projects that we do on cervical cancer screening. So usually when a woman goes through early stage of cervical cancer treatment, they are advised to stay away from conjugal activities for a period of time. So we receive a lot of violence on that because the men do not understand why are you not bringing down your skirt, and the woman knows I'm not bringing down my skirt because the doctor said I need to stay away. So when we talk about these policies, let us not forget the man, because truth be told, in our communities, the men are still the key decision makers. So leading them behind takes us back to the same circle. So involve the men also in women business, because in our homes, they call the shots.
Thank you very much. And we will be sure to let Ilona know that you framed it in that way. That's very interesting indeed. Sarah, you look like you...
Maybe, yeah,
please.
just for the previous question, just to add on what Stina said, join societies, I think is maybe a very concrete, from my personal experience. If you're working in a project, obviously everything starts locally, but in order to be global, join societies. You have local societies. If you don't, make one. I did that, it works. Then you join regional societies, global societies. That's how you actually scale up when you join societies and you work in a team.
Thank you very, very much.
And I have a suggestion for next year's session. I think the new generation should come also at the stage. So you have here two of them.
Woo! Thank you very, very much to all of you. Our tech team has just given me the red card. That's serious. So you can see we could go on and on with all of you. You've been a wonderful audience. I'd like to thank you as well for your attention. And warm, warm thanks to our host for making this fantastic discussion possible. Let's give everybody a big round of applause.